For many of us, our interactions with the healthcare industry are confined to doctor visits, pharmacies, and the occasional call to our insurance company. But even though that's where our communication ends, there's a lot going on behind the scenes that directly affects us. One of the key players in this complicated network are pharmacy benefit managers, or PBMs. And though you may have never heard of them before, PBMs have been influencing the industry since the 1950s.
So they were first started by pharmacies, actually, to function as claims processors. So basically paying out drug claims. Sort of evolved throughout the 70s and 80s, industry consolidation, expanding roles into then developing networks of pharmacies. Sort of in the 90s, we saw a trend of pharmaceutical companies purchasing PBMs and having their ownership. And then that shifted in the 2000s towards health plans, which is kind of where we're in now of independent PBMs or PBMs owned by health plans in these like vertically integrated organizations.
That's Eric Levine, a principal at Avalere Health, a healthcare consulting firm. Levine and his colleagues recently published a white paper on the role of PBMs in America's healthcare system. White papers are persuasive reports that aim to educate readers. Since this may be the first time many of you are hearing about pharmacy benefit managers, it won't come as a surprise that Levine believes there is a big knowledge gap of what PBMs actually do. They're often described as middlemen who negotiate drug prices between insurance companies and pharmaceutical manufacturers. While that's true, their role encompasses a whole lot more based on what their clients need. PBM clients include health insurance companies, government agencies, pharmacies, and employers.
And so what those functions can range from are sort of pure processing functions, which are things like processing claims. So getting the claim from the pharmacy, paying to the pharmacist, doing all the back-end management, creating the networks of pharmacies. So which pharmacies are in and out of network, similarly to how a health plan manages which provider is in and out of network. And that's for sort of managed care cost reasonings. Negotiating with pharmaceutical companies to negotiate on drug prices and rebates, creating formularies themselves so they can offer to their clients and say, if you're looking for a plan, like here's a formulary. And just sort of to break that down, a formulary is basically like the menu of drugs that the plan is offering that would be in network for drugs. So it's kind of like the drug network.
They can also be tasked with a range of clinical functions, such as managing drug safety programs.
So monitoring for members who are on particularly dangerous drug-drug interactions. Maybe the provider didn't catch that, so the PBM is doing that on the back end. Or even clinical outreach programs to providers to educate them on drug usage, on disease management, or to members themselves on adherence and the importance of taking drugs. So really they have this full suite of offerings, and then each client can decide, okay, I want my PBM to do X, Y, and Z for me. And then they negotiate the contract, the pricing, and all that's behind the scenes.
And though you may not know it, it's possible that you've spoken with a PBM representative. If you've ever called the number on your prescription or insurance member card, that call may have been routed to the PBM operating on behalf of the company.
PBMs have been working in the background for years now, and you would never know it because when you look at your health insurance card as a member, you see Cigna or Aetna, but you don't see the PBM. So they've always sort of been in the background doing these functions.
Since PBMs were created in the 50s, there's been some evolution of their place in the industry. Matthew Fielder is a senior fellow in economic studies and in the Center on Health Policy at the Brookings Institution. He says that today, the lines between these companies have begun to blur.
Companies that have PBMs also often have related businesses. So maybe many PBMs at this point also operate pharmacies, particularly mail order and specialty pharmacies. And in some cases, a PBM and the insurer are actually part of the same company. That's actually the typical case at this point.
Fielder says this merging of insurance companies and PBMs is a relatively recent evolution.
It used to be that we mostly had large independent PBMs. So they were separate from large insurers. But it's now the case that the Aetna-CVS merger means CVS is now part of a company that also includes an insurer, and the Express Scripts-Cigna merger means that Express Scripts, which is one of the other big independent PBMs, is now part of a company that includes an insurer. So that's been a fairly significant change in the market over the last number of years from a world where you mostly had PBMs that were independent entities that then contracted with an insurance plan to perform PBM functions, and you're now largely in a world where, for the most part, most plans are relying on a PBM that, even if it's not technically part of the insurer, is owned by the same company.
Fielder says this integration helps make certain operations much more efficient.
So in terms of setting up cost sharing, setting up coverage rules, and so on, and applying those rules, that's probably somewhat easier when the insurer and the PBM are the same entity rather than when they're separate entities. And there may be, I think the other place is where you're trying to coordinate the sort of medical side of the plan. So what's paying for, physician services, hospital services, et cetera. And the pharmacy side of the plan, it's probably easier to coordinate those two parts of the benefit when they're both being administered by the same company.
However, this change has created somewhat of an awkward situation for the insurers that don't have an in-house PBM.
And so what have we seen, I think, is that many insurers who don't have their own PBMs have become somewhat concerned about having to rely on a competitor for PBM services. And so we've seen lots of insurers starting to build PBM capabilities in-house that didn't have them before.
Since PBMs are the middlemen negotiating drug prices, they've come under a lot of criticism for being the cause of the high costs many people are forced to pay for their medication. However, Fielder says we may be wrongly placing this blame. He and two co-authors analyzed the role of PBMs in a 2023 research paper. Their investigation revealed that, contrary to popular belief, PBMs are not the main drivers of unaffordable drug prices.
The root of why drug prices are high in the US is because we give a monopoly to firms that develop new drugs. And we do that for a totally rational reason, right? We think that if we give a monopoly to firms that develop new drugs, they're going to be able to set a high price. That means developing a new drug is very profitable. And so there's a strong incentive to invest in the research and development needed to develop those drugs and hopefully, bring new cures or treatments to the market over time.
But the downside to drug patients is that manufacturers can charge whatever they want, often very high prices, since no one else can produce that same medication.
And that would be the case if we had PBMs, if we didn't have PBMs, and there's a trade-off there that we need to figure out how to balance. Now, what is true is that prices would probably be for drugs would actually be higher if we didn't have PBMs, because one of the things that PBMs do is they do have that function to negotiate the price of drugs with drug manufacturers. And I think the prices that they are able to negotiate are likely meaningfully lower than the prices consumers would face if we just accepted, whatever price the drug manufacturer set.
This doesn't mean that PBMs are totally free from blame. Join us next week as we discuss the criticisms of pharmacy benefit managers, including the Federal Trade Commission's ongoing investigation into their operations. You can find more information about Eric Levine, Matthew Fielder, and all of our guests on our website, radiohealthjournal.org. For more behind the scenes, follow Radio Health Journal on Facebook, Instagram, and X. Our writer-producer is Kristen Farah. Our production manager is Jason Dickey. I'm Greg Johnson.